يعطيكم العافية. بدكم تتحملونا، رح نضطر نلغي أو نأجل محاضرتين لبكرة عشان احنا تأخرنا في الوقت عشان الافتتاح. فبدكم تتحملونا كمان 20 دقيقة. بعد 20 دقيقة في حفلة، في فرقة موسيقية راح تكون موجودة مع دبكة، فرقة القوات المسلحة الفلسطينية، وبعدها إن شاء الله في عشاء. فبدكم تحملونا بس كمان 20 دقيقة، احنا تأخرنا عليكم عشان الافتتاح تأخر، متأسفين.
Okay, thank you. Well, our next speaker is Professor Paolo Pozzilli. The topic will be talking about SGLT2 therapy in type 1 diabetes, how to mitigate the risk of DKA. So the booklet is really, has a rich really CV, so you can take it from the booklet you have. I'm sorry for the short of time. You are most welcome, Professor.
Thank you very much for your kind introduction, and it's late. I try to do my best to be short and to give a talk that really raises your interest. This is a topic, the use of SGLT2 in type 1 diabetes, that definitely is one of the hottest topics at the moment. After 96 years of insulin for treating type 1 diabetes now, the European Medical Agency and some European agencies in single countries have authorized the use of SGLT2 in patients with type 1 diabetes. And this is a major advance. I was involved in some of the trials I'm going to discuss today, and I have to tell you that I have fantastic experience with my patients. And indeed, some of their patients have changed their life and achieved that metabolic control that Professor Chiarelli said we need to achieve. And indeed, I'm going to show you some of the data and, of course, talking about the issue of diabetic ketoacidosis. This is my disclosure. Now, I say, in what do these type 1 diabetic patients differ for? Now, these are all type 1s. You see young boys, young girls, young adolescents, adults, they are all type 1s. But type 1 is very heterogeneous disease. And then if we look about what we can call clinical laboratory data, you can find that there is a large heterogeneity among patients affected by type 1 diabetes. And just think about body weight, for instance, residual beta cell function, and compliance to therapy, and presence of complications. So it's not easy to treat type 1 diabetes, and ideally, we should prevent complication, and we should start from the beginning of the disease to offer the best possible therapy to our patients. Now, Professor Chiarelli said, I was very impressed when he said, well, glycated hemoglobin is very high, we have to reduce glycated hemoglobin. That is our aim in all patients with type 1 diabetes. And then I start talking about glycated hemoglobin and what are the results with the SGLT2. First of all, this is what is a slide that will be presented next week at the ASD, some of a large database on the glycated hemoglobin in patients with type 1 diabetes. And this is thousands of patients all together, different ages. And as you can see, the overall metabolic control from 7.9 to 8.0 to 7.9, about 70, 65, and 7.95 in all patients, clearly demonstrated that patients with type 1 diabetes are poorly controlled. And in particular, glycated hemoglobin is around 8%. So what can we do for that? Now, are therapies beside insulin type 1 diabetes? I'm sure you know that some patients over the years have been treated with metformin, although metformin was not indicated and was not licensed for type 1 diabetes, but patients were treated with metformin because some of them were overweight. Now, if we ask how many patients with type 1 diabetes are overweight today or obese, well, unfortunately, there are at least 1/3 of patients with type 1 diabetes that are overweight or obese. And this is something that you never expected about type 1. We always studied that type 1 as thin, slim patients, really nothing to do with obesity. But that the picture has dramatically changed because of the increased prevalence of obesity in the population. So now the phenotype of patients with type 1 diabetes has changed. Now, and then I start here saying that type 1, unfortunately, probably you cannot see from the back of the hall, but I just say that many patients with type 1 diabetes have now a type 2 diabetes phenotype. There are novel non-insulin therapeutic approaches available, and the SGLT2 have been now considered for treatment. Just to give you some info regarding how many patients have been treated in clinical trials, starting from 2015. 6,330 patients were treated in three major trials, the in tandem 1, in tandem 2, in tandem 3. These are with sotagliflozin. I was involved as a main investigator with sotagliflozin. Then we have the PIC1, the PIC2 with dapagliflozin, and then the IS2 and IS3 with empagliflozin. So data, and this is, I'm going briefly to show you what the results are, very consistent. We have never seen such consistency in terms of reduction of glycated hemoglobin treating patients with type 1 diabetes. Now, even though you cannot see well, but you could see that on the left, the reduction in glycated hemoglobin. And in this study, this is in tandem 1 with sotagliflozin, the reduction is 0.6 at 8 weeks, and after 52 weeks, the reduction in glycated hemoglobin is 0.5. And on the right-hand side, you can see the reduction in body weight. You can see that with the placebo, it's going slightly up, and then the 2 doses of sotagliflozin on the right-hand side show a decline in body weight of approximately 3 kilograms. What about in tandem 2, the other study done in Europe? Well, exactly the same data. After 8 weeks, you have a reduction of 0.6 of glycated hemoglobin, 52 weeks, 0.5. Reduction in body weight confirmed on the right-hand side. What about in tandem 3? In tandem 3, with patients with type 1 diabetes, you can see that 30% of patients in the trial have a glycated hemoglobin below 7%. 7% in patients with type 1 diabetes. And this is the study where you have the largest reduction in with sotagliflozin in glycated hemoglobin over a period of 24 weeks and even longer. So now move to dapagliflozin, the PIC1. Again, 0.6, starting at 4 weeks. In this case, after 4 weeks, you have already a reduction in 0.6% of glycated hemoglobin on the left-hand side. You can see compared to placebo. At 2 different doses, very similar results. We can go back to the dose of 5 and 10 milligram. And as you can see, that is maintained up to 24 weeks. That is the length of the study. And on the bottom part of the slide is the adjusted insulin, the median change in insulin dose. And as you can see, roughly, patients reduce about 10 to 15 units of insulin over a period of 24 weeks, maintained, and the reduction was necessary after 2 weeks of treatment. This is the PIC2, same study, same follow-up of 24 weeks. As you can see, reduction on the left-hand side of 0.5 of glycated hemoglobin. And on the right-hand side, you have the reduction of patients getting glycated hemoglobin below 7, 40%. Now, these are from the PIC1 and the PIC2, the target range compared to, and also the MAGE. So what was interesting with this study is that you could reduce the insulin dose, you can reduce glycated hemoglobin, but you don't have more hypoglycemia. And this is also something that is very relevant in these trials. study, the IS2 and IS3, again, same results. Reduction from 8.2 on the left-hand side, you can see the placebo, where the patient started with 8.8. These patients were really poorly controlled. From 8.8% after 4 weeks, glycated hemoglobin went down to 7.6 in 2 weeks. So we really, when you see the patient coming back to the clinic and live with this patient, you can really see the difference in their quality of life as well, because they were very motivated and very pleased to see a change in their life. Then the 20 weeks, you have the percentage of reduction of glycated hemoglobin, and after 52 weeks, with the empagliflozin was again 0.4, 0.5, similar to the other drugs, SGLT2 compounds. Now, said that, what about complications? Now, diabetic ketoacidosis, this is a nice meta-analysis published in Diabetes, Obesity, and Metabolism last year. And as you can see, there are all studies where SGLT2 were investigated in patients with type 1 diabetes. And on the top is diabetic ketoacidosis. And as you can see that favor diabetic ketoacidosis is on the right-hand side, the top line. And as you clearly see, there is an increased risk of ketoacidosis altogether. And in most of the study, there was an increased risk varying between 1 and 8% of patients included in the study. This is the percentage of ketoacidosis observed in this study. In real life, diabetic ketoacidosis occur in about 9 to 10% of patients with type 1 diabetes. The genital tract infection is the second complication. Also, as you can see, is moved on the right-hand side, indicating that this is increased, and we know that the genital tract infection are increased in patients with type 1 diabetes, so that is not a surprise. And as well with urinary tract infection, same story, but we are very familiar with this problem because we treat patients with type 2 diabetes, and we found that is a common adverse events. What are the risk factors that are associated with the SGLT2 inhibitors? That's the point. I think this is a crucial point. If you pay attention to what I'm going to say in the next few slides, you will see why, at least this is my position. I don't think that I have a biased position, because really this comes from my direct experience with patients. Even recently, we introduced many patients because the drug had been authorized in treatment, and we have seen no ketoacidosis, providing certain factors are really kept in mind. Now, first of all, risk level for DKA, moderate to high, reduced basal insulin for more than 10%, 20%. Some patients reduced by 50% their insulin dose. Why did patients reduce by 50% the insulin dose? Because when they wake up in the morning after 15 years of diabetes and having their blood glucose at 80, 90, or 100 milligram deciliter, they really don't think to inject themselves with insulin, because they always thought that if they wake up at 80, that means they should not take their prandial insulin for breakfast. That's the problem, because the insulin, the glucose levels are always around 100, 120 fasting. So that is why patients reduce the prandial insulin. Then that continued to be the case during daytime, and when they receive they need the insulin at night, the lente insulin, they actually are a bit skeptical, because they say, if I have 80, 100 of blood glucose levels and before going to bed, maybe I'm going to have hypoglycemia during night. And then they reduce the basal insulin as well. And so they wake up in the morning and they say 80 or 70 or 80, 90, and they will think, well, the following night, I have to reduce my basal as well, because I'm worried to get into hypoglycemia. They were living with hypoglycemia for 20 years, so hypoglycemia has been really their real serious problem, and therefore, by having such values, they think that they have to reduce insulin. So this is the first thing, and I tell you what we should do to avoid that. Then the other issue is reduce or inconsistent carbohydrate intake. They tend to reduce the carbohydrate intake. Excessive use of alcohol, but this is not an issue. But low to moderate is the vigorous or prolonged exercise. That's another issue that can reduce glucose levels. And of course, with the SGLT2 and also with the diuresis that increases, you can tend to have an increased risk. Minimal or low is the body weight. This is an important point, the BMI. Indeed, if you look at the EMA, the European Medical Agency, to approve the use of SGLT2, they approve in patients with BMI greater than 27, equal or greater than 27. So that is an important point to consider, because, of course, in patients that are slightly overweight, you have less risk of going into diabetic ketoacidosis. Now, these are the remedial action. If you measure blood ketones, of course, you are very familiar with that, less than 0.6 nanomolar, urine negative of no action needed. Trace or small trace of ketone bodies, 0.6 to 1.5 millimolar. Treat with 50 to 30 gram rapidly absorbed carbohydrate, maintain fluid consumption, and administer rapid-acting insulin or carbohydrate intake, and then check for blood urine ketones regularly. And you may seek medical attention if levels persist and symptoms are present. When you have moderate with 1.6 to 3 millimolar DKA, follow treatment recommendation, and then consider immediate medical attention. Then we have the key issue of the patient education. We spend really long period of time with patients to explain what is DKA, how they should avoid it, and the importance of ketone monitoring, the use of ketone monitoring, and treatment protocol for addressing ketosis, and guidance in when to seek medical attention. So patients should be educated. What we actually tell patients, and some of the patients that have a low insulin dose, because as I said at the beginning, patients are very heterogeneous. If you have patients that are on 0.6, 0.7 unit kilogram body weight because they are highly sensitive to insulin, or because they have some residual beta cell function, with 0.6, 0.7, these patients take very few amount of insulin in their normal life. Never stop the basal insulin. That's the point. Never stop basal insulin, because if you take 10 to 15 units of basal insulin, you never get into ketoacidosis for a very simple reason, because with that amount of insulin, the beta oxidation of the adipose tissue is not activated. Therefore, you don't get into ketoacidosis. But you have to keep your basal insulin. And then, during daytime, you may even reduce consistently the insulin dose, the prandial insulin, providing your glucose is within normal range, or if you have a light meal. So some of the patients, indeed, after 10, 15 years of diabetes with 4 injections a day, ending up having 1 basal insulin, 1 tablet in the morning, and using prandial insulin only when necessary at mealtime. So this, if you think a moment, is remarkable. And I tell you, that happened without having ketoacidosis in this patient, providing they never stop basal insulin. We have treated now regularly about 100 patients. We have seen 1 case of ketoacidosis. In 100 patients, 1 case. And that case was a patient that stopped completely insulin, because he found that it could stay and was even obese, a type 1 obese that stopped insulin and went into ketoacidosis. Now, I'm going towards the conclusion. The clinician education. So clinicians should acquire full understanding of the safe use and risk associated with the SGLT2 inhibitor therapy. So criteria for patient selection, training, educational need of patients, potential for missed DKA, treatment strategies that in this very nice review that Thomas Dunn had. Thomas Dunn, as you know, is a pediatrician. He's not an adult diabetologist, and Franco knows that. And even some pediatric clinics are now testing the SGLT2 for their patients, but this has been written, this consideration, by a pediatrician. The so-called STITCH protocol, that is stop SGLT2 inhibitor treatment for a few days, insulin administration, carbohydrate consumption, hydration with a suitable drink. Then we have the risk communication. So this also has to be clearly stated in the product labeling, in the website, the healthcare professional education, medication guide, patient alert card. So I'm going to conclude by saying that the SGLT2 inhibitor therapy, and I don't know if you can read, but I read that for you, is a promising option for adjunctive therapy for treatment of type 1 diabetes. Studies in this population have already demonstrated that the use of SGLT2 inhibitors confer significant benefits, including improved glycemic control, increased time in range, improved quality of life, and weight loss in patients that are overweight or obese. The major restriction on the wide use of these agents is definitely represented by the euglycemic diabetic ketoacidosis. However, the incidence of diabetic ketoacidosis in type 1 diabetic patients remain generally low. Strategies for mitigating DKA risk are vital to the adoption and safe use of SGLT2 inhibitors in all diabetes population, particularly those requiring insulin. So, key messages. Patients should be instructed not to discontinue basal insulin therapy under any circumstances. Moreover, if addition of SGLT2 leads to marked reduction of insulin need, discontinuation of the drug should be considered to avoid high risk of DKA. And of course, the patients, remember these patients that have been struggled with so many insulin injections for years, is definitely tend having normal glucose levels to reduce insulin and maybe stop it. In order to mitigate DKA risk, Ketone monitoring and education of patients and clinicians are mandatory. No reduction in basal insulin is recommended, whereas bolus doses should be adjusted individually based on blood glucose results. Although educational intervention for basic DKA appears to be effective, many patients are not familiar with ketone testing now and DKA, and this approach could also lead to lower adherence if ketone levels are mostly low or zero, and the patient does not feel that this frequency of monitoring is needed. This is another relevant issue. Cost also represents a major barrier to increased frequency of ketone monitoring, which could further discourage patients from the practice. And although urine ketone strips are convenient and much less expensive than blood ketone meter strips, the sensitivity and specificity of the urine test for diabetic ketoacidosis are substantially less than those of blood ketone measurement. So, ladies and gentlemen, I think that the next years will see, I believe, more and more an increased use of SGLT2 in patients with type 1 diabetes, and in particular also because patients with type 1 diabetes, in particular young adolescents and young adults, are now diagnosed earlier in the natural history of beta cell destruction. So most of these patients have a residual C-peptide, 0.3, 0.4 nanogram ml, and with that amount of C-peptide, clearly diabetic ketoacidosis becomes very, very difficult indeed, because at least 30% of their insulin production in this patient is endogenous. Thank you very much.
On time. Thank you very much. On time.